My name is Mara Antonoff. I'm an associate professor of thoracic and cardiovascular surgery at MD Anderson Cancer Center in Houston, Texas. I think this session covering surgery in stage 4 lung cancer is really important because we've really made a lot of strides in our care for patients with stage 4 lung cancer and the role of local therapy, particularly the role of surgery in recent years. Yet these practices really aren't well penetrated into our institutions and our hospitals around the country, around the globe. And I think it's pivotal that we help surgeons understand, first of all, why we're operating on stage 4 disease, how we can help people, and also to really address how to go about doing it. What are the metrics of a high quality operation in this space? Who are the right patients? What's the right timeline? And how do we get there? And so I think this session at the Society of Thoracic Surgeons 2025 meeting here in Los Angeles is incredibly important to inform people in this area overall. But we're kicking off the session with a talk specifically about why are we operating in stage 4 disease, because we recognize that not everyone is aware of what the recent data have included. And so I think it's going to be very exciting to share with folks what some of those data include. So to talk a little bit about kind of why we're operating in stage 4 disease at some of our institutions, why this is something that I do, I think it's helpful to kind of take a step back and realize that, stage 4 disease is metastatic. A lot of people have thought for a long time it's a metastatic problem, it's a systemic problem, and that surgery is something we think of as curative for early stage disease. Certainly, we've seen changes in our guidelines over time, but really the most substantial change that we saw, if you look, from 2001 to 2012, the major difference is that we're, now talking in the early 2010s about surgery in cases of solitary metastasis to the brain or solitary metastasis to the adrenal gland. And a lot of what we're doing that's really cutting edge and really pushing the envelope right now are operating on folks who have pretty extensive systemic disease, not just oligometastatic, but also polymetastatic. And I think a lot of things that have changed that have set us up to be able to operate in more extensive disease relate to our increasing data in the space of surgery and local therapy in general in stage 4 disease that began with initial studies in oligometastatic disease, so just a few metastases. But also we've seen in recent years the development of many incredibly efficacious drugs for patients who are good surgical candidates, young patients who are never smokers with oncogene-driven lung cancers. And so these are folks who may have new drugs that work particularly well in young patients who are eager for the most aggressive therapy possible. So there are a lot of nuances to why we're offering local therapy in these patients. And, I think it's pivotal for folks to understand that really the landmark oligometastatic trial that was published in Lancet Oncology in 2016 with Dan Gomez as the first author looked at local consolidative therapy compared to maintenance therapy or observation for patients really with 3 or fewer sites of metastasis. And this used patients who had surgery or radiation as their local therapy. But in this study, there was improvement in progression-free survival and time to development of new metastases and ultimately overall survival for those folks who had local therapy. An important caveat is that those folks who had EGFR mutations, which was a small group of that initial cohort, actually had even better outcomes for local therapy. We then embarked upon a number of really important studies, a couple of them by Kyle Mitchell in Clinical Lung Cancer in 2020, and Red Journal, also by Mitchell in 2019, and several others that show our institutional experience that even with surgery specifically, in the patients who had surgery, we see improvement in overall survival compared to maintenance or non-local therapy. Our data would suggest that surgery and radiation are both good tools. They can't be really compared head to head because we have such strong selection bias in terms of who gets surgery. But, aside from all of the data that we have looking at long-term outcomes of surgical local therapy, that we're looking at progression-free survival and overall survival in the areas of years, not months any longer, but we're looking at years for these patients with stage 4 disease. I think there are a lot of practicalities to why surgery is particularly favorable. And I think, I can summarize it that the rationale for local therapy in general are to eliminate the primary source of subsequent metastases, to minimize the risk of tumor cells being able to develop mechanisms of resistance, to debulk the disease so that we can leave a lesser disease burden for the effective drugs to treat, And with this goal of converting what has previously been thought of as a lethal disease to a chronic disease, it might not be no evidence of disease, but making it a chronic disease. All of those arguments fight for both surgery and radiation. But what are the practical reasons why these young, healthy patients come really wanting surgery? Number one, it helps us obtain tissue for an updated pathologic response and mutational analyses. It helps us address any residual cells that may be left after radiation that can provide potentially decades of control from a theoretical basis. And, we have to recognize the potential quality of life impact for the patients when they feel they've taken the most aggressive means of getting rid of their tumor. And these are young, healthy folks who may be able to tolerate even a complex operation. And what I've heard from a lot of patients, while this is not, an objective form of data yet, what I hear from patients is that it really provides patients and their family members some form of closure in answering the unknowns when we can get pathologic information to look at under a microscope. So I think these are all the reasons why, we do operate in stage 4 disease. It has to be done at a center of excellence and folks who have a lot of experience and resources in order to do so. But if we're going to operate, then we have to understand which patients are the best patients, what's the best timing with relation to their disease response to systemic therapy, and then how do we address things like extent of resection, nodal evaluation, and operative approach. And, we tried to address a number of these items in the recent Society of Thoracic Surgeons clinical practice guidelines on surgical management of oligometastatic non-small cell lung cancer. Those were just published online on January 10th, so we're very excited about those new guidelines, and those guidelines are actually also being presented here at the STS 2025 meeting in one of our other sessions, in which we're looking at all of the thoracic guidelines that have come out recently. But again, while we have the guidelines, I think there are a lot of nuances that need to be considered. There are a lot of places where we don't have enough data. So I think this session on why are we operating in stage 4 disease is going to have several other very important talks. Dr. Rocco is going to be talking about operating in oligo versus polymetastatic disease, which operation to do, what's the extent of resection. Dr. Kim is going to take us through that. And then in terms of the timing of surgery, we have a medical oncologist, Dr. Carl Gay, is visiting our societal meeting to help answer these questions about timing of surgery. And then patient selection, who should we be operating on? Dr. Raphael Werner is one of our colleagues from the University of Zurich, who also works with Dr. Opitz, Dr. Isabel Opitz at the University of Zurich, who has a lot of patients in this space as well. And I'm very grateful to have been able to collaborate our MD Anderson cohort with the University of Zurich cohort in the past, really just try to get more information about these folks because these operations just aren't being done everywhere. So I'm hoping that through this session tomorrow that we'll be able to help a lot of our attendees understand why many of us are operating in stage 4 disease and really how to think about doing it. What's the reason? How do we find the right patients? And what are the caveats of the timing, the type of operation, all the surgical considerations?